This is chapter 3 of diabetes mellitus. And let's start out with some drug therapy. So this is probably a review from last semester in Annette's pharmacology class. And fun fact, she's sitting right behind me in the office across the hallway, so we'll see if I get it right. Anyway, so let me share. Let's talk about drugs. So earlier in chapter 1, I talked about endogenous insulin. That's insulin that your body makes. So exogenous insulin is the body, or it is insulin that the body needs to take in through some sort of route. Insulin from an outside source. You can either have like this set up through injections, like with pens or with syringes, or you can have an insulin pump. The exogenous insulin is a must for type 1 diabetics. They will not survive without exogenous insulin, period. End of story. They have no insulin production capabilities whatsoever. It's all gone. They need insulin from an outside source and they need to inject it, period. Done. For type 2 people with type 2 diabetes, they will be prescribed insulin, exogenous insulin, usually during times of stress or as the disease progresses and they're unable to manage their glucose levels with previous therapies. Now, this is where almost every patient that I had in the hospital, if they were on intensive care or on progressive care unit, they were on, even if they were normally on metformin or glycoside or some other sort of oral medication outside of the hospital, once they became in the hospital on my wards, because I was where stuff went down, right? We were super sick. We were nurses caring for the super sick. So when you're in that, during that time of extreme stress, patients will be also prescribed exogenous insulin. So I was using insulin pens, even if they normally took metformin or glycoside. I also, if they were talking and able to understand what I was saying because they weren't on mechanical ventilation, I got a lot of education about why their pills got discontinued for the moment. And then as they went home, the doctor would evaluate whether they should go home on exogenous insulin or they could restart their oral tablet medications. So insulin preparation, there are 5 different insulin preparations here. You must know them. You must know them. And not only just their names, but you also have to understand how they work. So if you have an insulin aspart, a Novolog, usually comes in a pen, you're going to have a very rapid onset. It onsets within 30 minutes and it peaks between 30 minutes and 3 hours, and it only lasts for a total of 5. You can have Novolin R, or regular short-acting insulin, also available in a pen. And that will have a little bit longer acting onset, peak, and duration. Your long-acting insulins also come in pens. You can't just go by whether it's in a pen or not. Is moral of the story. Usually your intermediate acting insulins are not available to in pens. Usually they're available by vials, but that could be changing. Industry changes all the time. So just because when I'm recording this here in August, it's this way now, doesn't mean that it's going to be that way in tomorrow. Industry is always changing. We can also have inhaled insulin, and that is even a shorter onset than even your rapid actings. And the duration is therefore shorter, and the peak is therefore shorter. So the faster it comes in, the faster the onset of action, usually the faster the peak, and then usually the faster duration. Your long-acting insulins, they really don't have a peak, by the way. So they're given like as a 24-hour dose. Just so that you're aware, but you will need to, a word to the wise, you will need to know the green column and the orange column for not just for tests, but not just for tests. You're also going to need to know it for client care. You're going to need to know it for any sort of subsequent exams, and you'll need to know it for NCLEX. So these are actually really easy flashcard items. If you study well with flashcards, flashcard this stuff. Mealtime insulin. So what this does is it helps the client manage their postprandial glucose levels. So when we're doing mealtime insulins, postprandial, we usually use rapid acting or short acting. And we're going to be giving that really shortly after they've eaten, because that mimics the natural insulin response to meals. So here are this is information from the green and the orange columns on the previous slide as well. So just to let you know, these rapid acting ones are given just after. The short acting ones are usually given before a meal, but because they're given a little bit before a meal, and then maybe you were hungrier or weren't as hungry as what your eyes were, and we've already dosed you for what you're going to be eating, you can have some hypoglycemia reactions with that particular, or like, let's say you gave them their insulin, and then of course, that's the day that their meal tray is going to take 90 minutes to go up from the kitchen. Yeah, just Murphy's Law. So you have to be really careful with short acting regular insulin. I would almost, if you've got short acting on your MAR, I would almost wait until their tray is immediately in front of them before giving them their short acting insulin. So then that way you know that they're not going to have to waiting for food. Long acting basal dose background insulin. So you can be used with mealtime, sometimes between meals, and then it's overnight. Some type 1, type 2 diabetics use this, a lot of type 1 diabetics use this. They need to have that continual insulin dosage, so that way, because as their body has insulin available on demand for activities that are requiring the cells to use sugar, such as talking and using your hands to help you talk. Just for a small example. Long-acting ones are released steady and continuously with no peak action for many people, and onsets do vary. They're administered once or twice a day, usually either with morning and evening, morning or evening meds. So it's usually like they either have AM and PM doses, or they'll have an AM dose, or they'll have a PM dose. Do not mix these. If this comes in a vial instead of a pen, do not mix it or dilute it with any other insulin or solution. It is given by its own syringe, and it's given by its own site. Intermediate acting insulin, that NPH insulin, that lasts for about 12 to 18 hours, and it usually peaks within 4 to 12. You can mix this NPH with short acting and rapid acting. This is the one that comes cloudy. So this is the one that you're gently rolling in your hands. You're not going, this is not a milkshake situation. This is a gentle rolling in your hands. Just so that you're aware, that gentle rolling can also be used for lisprotamine and aspartame. And those are also cloudy, so you need to pay attention to your labels. Read your labels. Insulin is given by subcutaneous injection, not IM. The risk of hypoglycemia is too high. We need to have it go in the fat. Regular insulin can be given IV. That is under a specific set of protocols, and it's done by a specific set of specially trained nurses. And usually this patient is in a special ward, either they're in intermediate care or they are on an intensive care unit. In my facility, any client that was on an insulin drip had to be on progressive care or on ICU. There are other institutions that will have their med-surg units also with IV, but there are specific protocols and hourly glucose checks and very tight parameters that are surrounding those IV or that regular insulin drip, more in acute care or in high acuity care in term 3. You can't swallow insulin because it's inactivated and it's dismantled by gastric fluids. The GI system tears it up into bits, and it's not insulin anymore by the time it gets done in the GI system. There are also oral and non-insulin injectable agents. They work to improve mechanisms. They either improve insulin production or they help with that gateway. They help the insulin pump work better. So it can work, it helps with the 3 different defects of type 2 diabetes. So oral and non-insulin injectable agents are not used by people who have type 1 diabetes, period. So these oral and non-insulin injectable agents help with insulin resistance. They help kickstart insulin production, and they help hepatic glucose production as well. They can be used in different combinations. Sometimes people will be on an injectable and a pill. Sometimes they'll be pills only. Sometimes they'll be injections only. It really depends upon what works best for the client to be able to help them reach their health goals. All of our body chemistries are as individual to us as our fingerprints, and therefore we may have different combinations of different things to be able to get to goals. So bicronide is a classification of non-insulin treatments for people with type 2 diabetes. Metformin or glucophage is the hallmark sort of exemplar medication for this particular class of medications. It's most effective as a first-line treatment for type 2 diabetes. It's available in extended release, immediate release, and liquid forms. So if for whatever reason we have a person who doesn't really tolerate tablets very well, they can actually drink it. It reduces glucose production by the liver. So what it does is it slows down that gluconeogenesis process that's happening in the liver. It also enhances insulin sensitivity. So it helps with that cellular transport. And it also improves, therefore improving glucose transport across the cellular membrane because it helps with insulin sensitivity on the cell wall and cause weight loss. And it also can be used in prevention of type 2 diabetes. So we may have people who are on metformin who are pre-diabetic in order to prevent type 2 diabetes. So here's there is some big darn deals with metformin. You have to hold it if they're going to go under surgery or if they're having radiologic procedures with contrast medium. Metformin is one of those, because there's 2 different ways the medications are processed, right? They're either processed by the liver or they're processed by the kidneys. Metformin is processed by the kidneys. Contrast dye is also processed by the kidneys. So if you put metformin, which is hard on the kidneys, and contrast dye, which is hard on the kidneys, in the same human being, you run the risk of giving that human being an acute kidney injury. Bad deal. Complete kidney shutdown. So let's avoid that. So a day or 2 before and at least 48 hours after, if their serum creatinine levels are just like normal, that's like the holding guidelines for metformin. If for whatever reason the client already has reduced kidney functions at baseline, like they're walking around and they've got chronic kidney disease type 2 or chronic kidney disease 2 or higher, consider advocating for additional countermeasures to help those kidneys, especially when they're going to be going surgery or anything with contrast medium. When I was working in the cath lab, if we had somebody who was on metformin or who had chronic kidney disease, we automatically like changed the entire way we used contrast medium. Plus then we would have nephrology on board as well to be able to watch those kidneys and be able to help with any sort of adjuvant therapies that might help support those kidneys, because those kidneys are going to need extra support when they're having procedures like those. Contraindications. If a person has renal, liver, or cardiac disease, they have a history of lactic acidosis, if they have a history of iodine, and if they need a lot of contrast for whatever reason, that contrast and the metformin together will cause acute kidney injuries and complete kidney shutdown on a temporary basis, perhaps even so severely that it's on a more permanent, intermediate to permanent basis. If they have excessive alcohol intake, we also are going to be advocating for them to not have metformin. It makes your stomach terribly upset My friend Lynn took metformin, and the first 6 months she started metformin because she was pre-diabetic. All she could keep down was applesauce. So there are a lot of, like, there's nausea and there's increased GI motility when it comes to metformin. So you'll need to be working with your clients to work on taking their metformin with food to help minimize those GI side effects. Sulfonylureas increase insulin production from the pancreas, but their major side effect is that they have hypoglycemia. So I know I mentioned glycoside before. Glycoside tends to be my go-to when I'm talking about sulfonylureas. There's also glyburide and there's also glimepiride as well. So there's a few different examples of sulfonylureas. There are sodium glucose cotransporter 2 inhibitors, and they block the reabsorption of glucose by the kidney, and they increase urinary glucose secretion. Farxiga is one of these. Jardiance is one of these. Invokana. I've seen these medications. They've got really good commercials for. If you watch TV with commercials, you'll see these every now and again. They've got some really good commercials on a variety of different channels. That is all that I have for drug therapy. So I'm going to stop sharing, and I'm going to continue on with nutrition and exercise in the next chapter.